Hello, I am Patrícia, and I'm here to share some pitfalls regarding ERG in clinical assessment, treatment, and outcomes of patients affected by retinal vein occlusions beyond academic settings. Moreover, I have the honor to present two cases evaluated by a great friend of mine, Dr. Marcelo Teixeira from Oftalmopampa, Brazil. Patients 1 and 2 pretty lovely ladies and also good candidates for a retinal vein occlusion. Both of them have systemic arterial hypertension with poor control for a long time. So it's not surprised that their retinal arteries become thick and hardened to the point of obstructing small veins, as happened in their right eyes. Patient 1 is 63 years old and had a 1 week story of a sudden visual blur followed by moderate, non-painful visual acute decrease in her right eye. Patient 2 has a 2 months history. She is 87 years old and complained of painless progressive spots in one eye. For patient 1 in OCT, we can observe localized intraretinal edema in the inferior arc that extends to the inferior portion of the papillomacular bundle. We have a branch retinal vein occlusion with localized macular edema. For patient 2, we can observe massive hemorrhage and diffuse intraretinal edema. We have central retinal vein occlusion with diffuse edema. Concerning the fellow eyes, for patient 1, OCT looks normal, while for patient 2, we can see macular thinning. And now I have two younger ladies to introduce you. This one in blue, it's me, and in green is Ms. Stella Teixeira. Stella is Dr. Marcelo's wife. She had never ever seen a handheld ERG before, and I had a great time teaching her how to perform the examination under non-mydriatic and photopic conditions. And I was really proud of our results. We have beautiful comparable waveforms to the expected ones. And I can tell you that my dear top model really rocks on ERD. Now I want to show you the ERG results from our cases. We used the RETeval in accordance to ICV guidelines for monocular evaluation under scotopic and photopic conditions. But first, let's take a closer look inside the retina. We know that retinal vein occlusions are known to promote inner retinal hypoxia, different degrees of retinal hypoxia, including ischemia. The Ph.D. shift leads to a self-destructive cascade that changes the retinal bioelectrical activity. And it means that different steps of phototransductions are comprised. So not only the inner retinal, but also the outer portion is affected, despite its own choroidal blood supply. And as we can see here, not only the ganglionar cells are affected, but also the resting potential of the eye is abnormal in retinal vein occlusions. We have disrupted, reduced, and prolonged light rise of this resting potential. Now that we know what's happening inside the retina, it's easy to understand why full-field ERG is priceless regarding retinal vein occlusions. When we know what to search for, it's easy to detect patients under high risk of developing neovascular glaucoma and to detect it if it's ischemic or not ischemic, and to determine a prognosis and to do the follow-up. Now let's discuss this theme, taking a look at our own patients. Here we have the scotopic B wave, and B waves are generated in the middle retinal layer, in which the blood supply is provided by retinal circulation. Accordingly, the B wave amplitude is believed to be a good indicator of the retinal circulation, besides reflecting the overall retinal function. As we can see in patient 1, retina might be affected by a lesion that is smaller enough to not decrease the amplitude of the B wave. But for the second patient, we do not have a wave here. Now let's take a look at the maximum combined responses, where we can extract the ratio between B and A wave as a good indicator of retina blood and oxygen supply. It's important to notice that when the B wave ratio becomes very small, it's similar to what was observed in central retinal artery obstruction. So one can conclude that the overall retinal ischemia is very severe. For patient number 1, we can see that the amplitudes overall are normal but slightly diminished. And we have to consider that this retina is under a vascular disease because this patient has a systemic arterial hypertension. For patient number 2, we don't have a response here for the affected eye, and the fellow eye seems pretty normal. OPs are these small but high-frequency oscillations on ascendant limb of the B wave that are generated by amacrine cells. For sure, OPs are related to the vascularity of the retina, but abnormally flattened OPs are attributed to a saturation effect at higher levels of light adaptation due to a disruption of the interaction of cone and rod's contribution to the OP waveform. And we can see that the OPs of our patients are flattened. We have another scotopic response, the same pattern. Now let's turn on our lights and see what happens. Then I can also calculate a BA ratio here. For the first patient, the cone response seems okay. For the second patient, the fellow eye presents a thinning macula, and we have a good photopic responses, but you can see that the flicker is not this good. It's a little bit prolonged, and we have to take a look here. And what I can tell the patients? I can tell for the first patient that she had a branch retinal vein occlusion, non-ischemic type, but she has to take care because this can happen in the other eye, and she has to control her systemic hypertension. And for patient number 2, I have to tell her that he had a central vein occlusion, a ischemic type, and I have to do a treatment here because she's at high risk to develop a glaucoma. And so I can tell you that handheld ERG in vein occlusion is really a good method to perform a retinal evaluation, and that we can extract really good parameters to analyze the patients and to see what to do and to tell them what can happen to their eyes. Thank you so much for listening, and have a great time doing your ERGs. I hope that it's helpful for you.